Good afternoon, class. So today we're going to discuss disorders of lipoprotein metabolism or your dyslipidemia. Again, I'm Dr. Ana Angelica Macalalad-Josue. So for the outline of our session for today, first we're going to have a very brief review of your lipoprotein metabolism. Next, we're going to discuss a little bit of disorders of elevated cholesterol and triglycerides, as well as disorders of reduce HDL cholesterol. And lastly, we're going to talk about screening, diagnosis, and management of disorders of lipoprotein metabolism by discussing the 2020 dyslipidemia guidelines for the Philippines. So if you remember your lipoprotein, these are proteins that are, it's a combination of your lipid and your protein that is essential for transport of poorly soluble lipids such as your cholesterol, triglycerides, and fat-soluble vitamins through body fluids. So from one organ to the other, let's say, for example, from the liver to your target cells. No? So your lipoprotein is important on that. So the density and size distribution of the major lipoprotein particles are illustrated in this diagram, which is found in your Harrison. And as you can see, the higher the density, the smaller the size of your lipoprotein. So for example, your high density lipoprotein would be this small, and it has the least lipid content, and your VLDL, no, or your VLDL, which is your very low density lipoprotein, will have a much larger size, and the one with the largest size would be your chylomicron, and these are your most lipid-rich lipoproteins. So the density of a lipoprotein particle is primarily determined by the amount of lipid per particle. So your VLDL and your chylomicron have the highest lipid content. And there is a strong inverse relationship between density and size. That's why your HDL is the least lipid rich. No, it has been tagged as the good cholesterol. No. So your apolipoproteins are components of your lipoprotein that is involved in the assembly, structure, function, and metabolism of your different lipoproteins. They can activate enzymes that are important in lipoprotein metabolism and also act as ligands for your cell surface receptors. So this is an example of your structure of your HDL, and these are the different apolipoproteins on the surface of the lipoprotein. So you have your large ApoA1, your ApoE, ApoC, your ApoA2. So they all have different functions for each specific lipoprotein. So here are the different apolipoproteins. You have your ApoB, which is a very large protein, and is the major structural protein of chylomicrons, VLDLs, IDLs, and your LDLs, or your low-density lipoprotein. Your examples of this are your ApoB48, ApoB100. So it depends on which lipoprotein we're talking about. Your ApoA1 is found in virtually all HDL particles. And your ApoA2, is found on approximately 2/3 of all HDL particles. Okay, and your ApoC1, 2, and 3 is involved in the metabolism of your triglyceride-rich lipoproteins. And lastly, your ApoE is involved in the metabolism and clearance of triglyceride-rich particles. No? So your chylomicron is your main transporter of your triacylglyceride across the different body fluids, no, from your from your gut to your liver to your capillaries. So I will attach the link to this video that explains the physiology of your the biochemistry of your chylomicron metabolism. So you can watch it on your own. So I'll attach the link on our Canvas module. Next, it's covered. Your VLDL, or your very low density lipoprotein, is involved in the transport of hepatic lipids from the liver to the periphery. So its main purpose is to distribute your triacylglycerides from its synthesis in the liver into the periphery, okay, into your target cells. And lastly, your HDL, or your high-density lipoprotein, and your HDL is involved in reverse cholesterol transport. So from the periphery, it will try to get your triacylglycerides and your cholesterol and transport it back to the liver for metabolism. That's why this is good cholesterol. It sequesters your cholesterol and your triacylglycerides for degradation. Okay, so it can actually protect you from hyperlipoproteinemia. So now let's go to the different disorders of lipoprotein metabolism. So dyslipidemia is like an umbrella term for people with abnormal lipoproteins, no? And it has been shown that dyslipidemia predisposes patients to develop atherosclerotic cardiovascular disease. On the other hand, if you have hypertriglyceridemia, you are at an increased risk for acute pancreatitis. No, I had a patient with that. No, with poorly controlled diabetes, and because of the poorly controlled diabetes, he had markedly elevated triglycerides. No, and he got lost to follow up. He came back to me after a bout of acute pancreatitis because of hypertriglyceridemia that was left untreated, no? And the acute pancreatitis actually worsened his diabetes because, of course, you destroy also some of the beta cells during the acute pancreatitis. Okay, so going back, there are discrete nodes that regulate lipoprotein metabolism. One, if you remember from the video that if you review the video that I showed earlier on your own, you will see there the different steps, no? And these are the important steps that you need to remember. So first, the assembly and secretion of your triglyceride-rich VLDLs by the liver, the lipolysis of triglyceride-rich lipoproteins by lipoprotein lipase, and your receptor-mediated uptake of ApoB-containing lipoproteins by the liver, and your cellular cholesterol metabolism in the hepatocyte and the enterocyte, and lastly, the neutral lipid transfer and phospholipid hydrolysis within the plasma. Okay? So, if you have problems with your dyslipidemia caused by excessive hepatic secretion of your VLDL. Remember what the function of your VLDL is? It distributes triacylglycerides into the periphery. So that's problematic if you have excessive secretion of your VLDL because you will have excessive distribution of your triacylglycerides and cholesterol into the periphery. And this is one of the most common causes of your dyslipidemia. Your lipid profile would look like this. You have a elevated high fasting triglycerides, you have a low HDL with variable elevations in your LDL, cholesterol, and an elevated ApoB. And the major factors that drive hepatic VLDL secretion is number one, obesity, your insulin resistance, a high carbohydrate diet, because with insulin resistance, obesity, high carbohydrate diet, you will have excess sugar, excess carbohydrates, and the carbohydrates will eventually be stored as your triglycerides from the liver, no? And also alcohol use, exogenous estrogens, and of course, your genetic predisposition. What are the secondary causes of your VLDL overproduction? So you have your high carbohydrate diet, no? And this is converted to the food, the excess carbohydrate that you eat, no, from your diet that are not utilized or burned are eventually converted to free fatty acids in the liver. And usually this manifests as elevated triglycerides. So I can usually tell if a patient eats a lot of carbohydrates if the triglycerides in the lipid profile is markedly elevated. So I'll tell them, kumain po kayo ng, marami po kayong kumain nun. And then they will tell me, oo nga doktora, nakaka 2 cups of rice po kasi ako, mahilig po ako sa milky. And it shows no in the lipid profile that their triglycerides is indeed markedly high. So alcohol is also a secondary cause of VLDL overproduction because it inhibits hepatic oxidation of your triacylglycerides. And you also have your obesity and your insulin resistance because it promotes fatty acid synthesis in the liver and decreases your lipoprotein lipase activity. So it limits the metabolism of your triacylglycerides. And then next you have your nephrotic syndrome. Sorry, that's nephrotic syndrome. And this is because of your hypoalbuminemia leading to decrease in protein synthesis. That's a decrease. And lastly, you have also Cushing syndrome. So these are the less common causes of VLDL overproduction, which is usually genetic. You have your familial combined hyperlipidemia. Usually 20% of patients who develop coronary heart disease under the age of 60. You have your lipodystrophy, generation of adipose tissue, generally or in certain fat depots is impaired. So usually they have a different body composition. So these are the, next we go to your dyslipidemia caused by impaired lipolysis of your triglyceride-rich lipoprotein. And this is because of your impaired lipoprotein lipase activity. And how would it look like in your lipid profile? You will have an elevated fasting triglycerides, low HDL, normal LDL-C, and ApoB. The usual secondary causes of this is your obesity and your insulin resistance. So if you markedly elevated triglycerides, your serum would look lipemic. No, it would be described by the medtech in the report. The less common causes of this type of dyslipidemia are your genetic causes like your familial chylomicron syndrome, your familial hypertriglyceridemia. Although familial hypertriglyceridemia is relatively more common among Filipinos. And this can cause significant coronary heart disease and usually treated with statins. If the patient is not high risk, meaning the patient doesn't have history of MI, stroke, no history of diabetes, you can actually treat with dietary and lifestyle changes alone. And usually, for hypertriglyceridemia, and this is what I follow in my own practice, because this is what is listed in the guidelines. If the triglycerides is more than 500 milligrams per deciliter, that's the only time that I treat with a fibrate. The normal level is 150. Between 150 to 500, if the patient is not very high risk, I usually just treat with diet, very low carbohydrate diet. I refer to a dietitian. I make sure he understands that the elevated triglyceride is coming from the excessive calories and the excessive carbohydrates, so that we can try and lower it down further. And most of the time, it really does work, except if the triglycerides is more than 500. Because if the triglyceride is more than 500, it further increases the risk of the patient developing pancreatitis. Okay, so it's important to educate your patients what is the source of this elevated triglyceride so that they know how to intervene. You can do a combination of both, of course. If the patient is not I ask them to do early follow-up so that I'll be able to keep track if the diet is indeed being followed and if the diet is indeed working. If not, then that's the time that I'll start the patient first with a statin and then with a fibrate. And you can actually observe this, no, through your physical examination. If you look at the retina, and the retina would look like this, no? You will have lipemia retinalis. The fats is in your retinal vessels, no? And this is your normal retina. Okay. Some patients would also have this dome-shaped papules, no, firm yellow dome-shaped papules on the arm of a 46-year-old man with hypertriglyceridemia, hypercholesterolemia, and hyperglycemia. So if you have patients or even relatives who have this skin manifestation, have them screened with a fasting lipid profile. Next, we go to dyslipidemia caused by impaired hepatic uptake of ApoB containing lipoproteins. And this is mostly due to downregulation of your LDL. This actually results from downregulation of your LDL receptor activity, especially if you have a diet high in saturated and trans fats. No? So there are some genetic variation that reduces the activity of your LDL receptor pathways. And the more common causes of this is your hypothyroidism and your chronic kidney disease. Now, remember, hypothyroidism will slow down, no, the different metabolic activities in the body, and that includes your LDL receptor activity, as well as your CKD. The less common cause of this is your primary cause or your genetic cause, which is usually your familial hypercholesterolemia. Also, in familial hypercholesterolemia, you have a markedly elevated LDL cholesterol in the absence of your hypertriglycerides. And sometimes it can be from a loss of function mutation of your LDL receptor or a reduced rate of clearance of your LDL. No? And it is usually an autosomal dominant disease. And if you trace the patient's family history, you would have premature CHD, either an MI or a stroke less than 55 years old. So that's one of the most crucial things, no, that you really have to ask in your family history, no, aside from your cancer. Now, that's the number one thing that I ask in the family history, the history of premature coronary heart disease. Okay? So how do we treat? Usually we treat with a statin plus or minus a cholesterol absorption inhibitor. And if it's the cholesterol is still markedly elevated, then you can do LDL apheresis or use your PCSK9 inhibitors. Although these PCSK9 inhibitors, as far as I know, is not available locally in the Philippines. So usually these patients would manifest with xanthomas, usually in your tendons, in your Achilles tendon, or in your tendons of your hand, your tendon xanthomata. Okay, so if you see patients with that, no, suspect familial hypercholesterolemia. These are the other cutaneous manifestations of your familial hypercholesterolemia, no? Deposits of lipids, no, in the different areas of the body. This is your corneal arcus in your familial hypercholesterolemia. And you can see there's some fat deposition, no, in your cornea as well. Okay. Next, we go to your dyslipidemia caused by impaired hepatic these are the other causes of your impaired hepatic uptake of your ApoB containing lipoproteins, no? And these are all very, very rare conditions. I've never seen any of this in my lifetime. So these are just nice to know that there are rare cases. But of course, you always have to consider the more common ones first before delving or even considering this genetic causes. Okay. So these are the different physical manifestations. So if you see patients with this, no, with different symptoms in the hands, in the knees, no, you have your xanthomas, striatum palmari, then suspect familial causes of your dyslipidemia. This one, your palmar xanthoma is pathognomonic of your familial beta lipoproteinemia. Okay, so have them screened with a simple fasting lipid profile. Okay, it has to be fasting. What are the additional secondary causes of dyslipidemia? Have been liver disorders. Remember that the liver is very central in your lipoprotein metabolism. So if you have problems like hepatitis, no, from let's say hepatitis B or alcohol or your drug-induced hepatitis, it can increase your VLDL secretion and increase no peripheral distribution of your triacylglycerides. Cholestasis can also result to hypercholesterolemia. Some drugs, such as your estrogen, your pills, no, can increase your VLDL and therefore increase your triacylglycerides. And also, unique to this will be an elevation of your HDL. No? Medyo ano siya, parang odd man out. At there, in the background of your elevated VLDL, you have an elevated HDL as well. And this is pathognomonic of your estrogen use. So how do we screen and diagnose patients who have disorders of lipoprotein metabolism? So something as simple as your fasting lipid profile, at least 12 hours. Some labs will allow 10 hours, but usually we want it to be about 12 hours, no? Because your triglycerides will be affected by a meal, okay? So your LDL, you compute, usually in the lipid profile, it's already there, no? But if you compute the LDL, it's usually derived from your total cholesterol minus your VLDL, which is your triglycerides divided by 5 minus your HDL cholesterol. But you cannot use this formula if the triglycerides is more than 400. So sometimes the lab would say LDL not calculable. Yeah. Because of the markedly elevated triglycerides. Non-HDL, remember this, no? This is not very this is not reported most of the time in your lipid profiles. You have to compute it for yourself, no? You just subtract total cholesterol minus your HDL, no? So HDL and total cholesterol is not affected by fasting. Mostly it's your triglycerides that is affected by your fasting. Okay, so if you're only interested with your total cholesterol, then you don't really need to ask the patient to do fasting anymore. But most of the time, like 99% of the time, I ask them to do fasting, except for exceptional cases. So here is a table of how you can try to generate, no, the differential diagnosis if your patient presents with dyslipidemia. Most of the time, the secondary causes is more common than your genetic causes. Okay, so it's important to rule out secondary causes first, simply because they're more common before going into the more rare ones. Except if they really have presenting features that are pathognomonic for a particular familial disorder. So for severe hypertriglyceridemia, how do we diagnose? The fasting triglycerides is more than 1,000 and the cholesterol to triglyceride ratio is more than 10. We consider familial hyperchylomicronemia. For patients who have severe hypercholesterolemia and the LDL cholesterol is very high, consider a genetic cause. No, look for what happened to the patients, to the parents, do they have premature CVD, no? Or they have physical manifestations as well. Okay? Just a little bit of a break. So what do we do now? If you were able to diagnose a patient to have a lipoprotein disorder. So here are our major goals. So number one, if your patient has severe hypertriglyceridemia, we want to make sure that we prevent this patient from developing acute pancreatitis. And next, of course, we want to prevent these patients from developing cardiovascular disease and other related cardiovascular events, such as your stroke, peripheral arterial disease, and so on and so forth. So for patients with severe hypertriglyceridemia, the first line would be lifestyle. No? We want to advise patients to stop alcohol drinking, discourage excessive intake of carbs. So this is one of the few instances where I advise the patient to have a very, very low carb diet. No, one of the rare. I usually don't advocate for very, very low carbohydrate diet like keto. I don't advocate for that. But in this case, I do advise patients to really minimize with guidance from a registered dietitian. And also, aside from that, we want to restrict dietary fat intake, encourage aerobic exercise, weight loss, and in patients where it is indicated, we can also advise patients to undergo metabolic surgery or your bariatric surgery. So we only treat only if the triglycerides is more than 500, despite the normal value being less than 150. So if you do decide to treat, no, we can give your fibrates, your phenofibrate. The dose would depend on the level. Optional, although in the guidelines, in the Philippine guidelines, they don't advocate for omega-3 fatty acids. Although for me, some patients, if the fibrates are already maximal in dose, I do try some fish oils. But these are your very, very high dose fish oils as an adjunct, but not as a first-line therapy. Your nicotinic acid is also an option, but as far as I know, this is not locally available in our country. So how do we manage our patients to help prevent them from developing cardiovascular disease if they have dyslipidemia? Of course, your lifestyle, as I mentioned earlier, and pharmacologic. I'll discuss that later now. So when deciding to treat, you take a look at the LDL cholesterol level. You not only consider your LDL cholesterol level, but also your cardiovascular risk. So there are some patients who have not very high LDL cholesterol levels, but since they're very high CV risk, we do give them pharmacologic treatment because their treatment targets will be much lower. Okay. So others are this and your LDL apheresis, but these are in extreme cases. So now we go to our very own clinical practice guidelines for the management of dyslipidemia in the Philippines. This was for, published and released in 2020. Okay. By a joint effort of the different stakeholders for dyslipidemia. So dyslipidemia is not just for endo, not just for cardio, it's for all physicians. Okay. So here are some of the more relevant, or not really relevant, but more of the more common questions that you'd probably encounter when you go into your clinical practice. No? So I just pick out some of the clinical questions, and these slides were taken from the presentation of the clinical practice guidelines back in 2020. So among patients with no diabetes and without atherosclerotic cardiovascular disease, but with multiple risk factors, should statins be given for primary prevention? Primary prevention meaning the patient has not had any cardiovascular event yet. So they recommend statins for the prevention of cardiovascular event for patients who are more than 45 years old and with an LDL cholesterol level of more than 130 and with more than or equal to 2 or more risk factors. So these are the risk factors that they identified: male sex, postmenopausal women, smoker, hypertension, BMI of more than 25, family history of premature CHD. So please don't forget to take that in your history taking. Presence of microalbuminuria, proteinuria, and presence of left ventricular hypertension. So you have two of them, then and you have an LDL cholesterol of more than 130, 45 years old and above, then you're warranted to give your patient a statin. Okay? So here are the different treatment targets. So persons with no clinical ASCVD for primary prevention, our target is less than 130 LDL cholesterol for your HDL. For any person, no? More than 40 if it's male, more than 50 if it's female. Okay? 50 for females, 40 for males. So I'll ask that in the exam. For your triglycerides, now the normal value is less than 150, and that's also our target. For persons with diabetes, without any other risk factors, is less than 100. For patients with diabetes with more than or equal to one risk factors, we give the patient, we target less than 70. In patients with atherosclerotic cardiovascular disease, patients who has had history of MI already or stroke, no, we want to target even lower, less than 55 years old. Okay. So we discussed earlier familial hypercholesterolemia. So in patients who are high risk and identified to have FH, should statin therapy be initiated? Of course, yes, this is strongly recommended. And how to detect if your patient has familial hypercholesterolemia? If you suspect your patient to have one, we don't have readily available genetic testing in the Philippines. So they actually develop a scoring system that you can use if you suspect your patient to have FH. So if the score is more than 8, then you have definite. 6 to 8, you have probable. 3 to 5, possible. Less than 3, unlikely. Okay. So what about patients with chronic kidney disease? These are also very common patients that you will encounter in your clinical practice. CKD is considered a coronary equivalent, no? And this is because dysregulation of lipoprotein metabolism can occur, no? Even in early stages of kidney disease, and can result in significant changes in the apolipoprotein, even if there are no changes yet in the lipid levels, no, in your lipid profile. And the major lipid abnormalities in CKD is a decrease in your HDL, an elevation of your triglyceride-rich lipoproteins, elevated lipoprotein lipase. And then in patients with peritoneal dialysis, usually have elevation of your LDL cholesterol levels because of constant dextrose absorption. So what do the other guidelines say in patients with, and that's your KDIGO guidelines, which is usually the sort of the Bible for CKD patients, no? In patients with dialysis-dependent CKD, avoid initiation of statins or statin-ezetimibe combinations. But if the patient is already on statin therapy, even before dialysis, then you can continue it even at the time of dialysis initiation. For patients who underwent kidney transplant, you can give statins. How about patients with acute coronary syndrome? Should statin therapy be given? Yes na yes. Okay, it is very important for these patients, no, who develop an MI to receive early high-intensity statin that is maximally tolerated, no, and should not be discontinued. And this is immediately. Usually when patients arrive at the ER with chest pain, we suspect an MI, we give already either a rosuvastatin 40 or an atorvastatin 80. Those are maximal, one of the maximal doses already. So if you remember from my diabetes lecture, no, we have different intensities of your statin. You have your low intensity, your moderate intensity, and your high intensity statin. And it's important to determine the high intensity statin. You only have two, your Ator and your Rosu. Okay, and anything less than that is your moderate intensity. Okay, so you have to remember these doses because it's a very, very common drug that you will be prescribing when you go into your clinical practice. So how do we prescribe statins, no, for secondary prevention? Meaning patient has already had an MI or already had a stroke and we want to prevent them from developing another event, no? And the evidence was able to show a net benefit favoring high intensity statin therapy in reducing the critical outcome of MI. Okay, so it's very important that patients who have these events already to be maintained. So patients, when they are prescribed with statin, they think that when the statin is already within normal, they can stop. This very common common practice of our patients. So I tell them that we are not giving your statin just to lower down your cholesterol, but we want to lower it because we want to prevent you from getting another heart attack or a stroke. And you will see if you stop it and we check your lipid profile again, it will go up again. And we want to prevent that from happening. So sometimes I even go as far as telling them the lower the statin, the lower the LDL, the better, especially for patients who have high CV risk. Okay. For individuals with documented ACS not at goal, despite maximally tolerated statin, should ezetimibe be added? So the answer there is yes. We want to make sure that your patient is on target, no? Especially for your high-risk patients. So again, remember, if there's only one thing that you should remember from my lecture, it's this slide, okay? And the statin slide, okay? So persons with no clinical ASCVD, want to prevent them from developing a cardiovascular event, you target less than 130. For patients with diabetes, no risk factors, less than 100. Diabetes with risk factors, less than 70. With atherosclerotic cardiovascular disease, lower, less than 55. Individuals with clinical ASCVD, less than 55. Familial hypercholesterolemia, without ASCVD, less than 70. With ASCVD, less than 55. And remember, HDL cholesterol target, males 40, females 50. And the triglycerides, less than 150. So please memorize this, okay? So among individuals with ASCVD, should omega fatty acids be given on top of statin therapy? The answer is no, because it's not recommended. It doesn't have any additional benefit. So this is very common practice, you know. Some relative from US or from abroad will give a big canister of fish oil. I take fish oil. What for? So because there's already a trial that there's already a trial, no, that showed us, I forgot the name of the trial, but it does not have any additional benefit, no, for your patients, even in primary prevention also. Okay. So remember earlier I talked to you about your non-HDL. So how do we compute again? So total cholesterol minus HDL. So that's your, what's that? That's your non-HDL. So that's your LDL plus your VLDL. No? So this is a secondary target that quantifies all atherogenic lipoprotein particles that includes your VLDL. And the target level in the guidelines is 30 milligrams per deciliter above the target of LDL cholesterol. So for example, your LDL is 70, your target non-HDL is 100. So make sure you compute for that. You target both, okay? So this is the rationale for the difference of 30 milligrams. So you just read up on that. But that's the crucial, is that knowing what your target is. Okay, so again, your target for non-HDL is 30 milligrams per deciliter above target LDL. And then lastly, the Philippine guideline also illustrated or summarized the guideline into this algorithm for the management of dyslipidemia. First, you have to take the patient's history and physical exam. Look for risk factors: smoking, history of MI, stroke, history of peripheral arterial disease, family history of premature CVD, and other comorbid conditions. Then you ask patients to first lifestyle modification. No, it doesn't mean there are lots of drugs out there. You skip this part. It's very crucial. Sometimes very mild. There are some cases that you can actually just start managing first with lifestyle, especially if the patient is just low risk. Okay, if the patient has diabetes, remember in my lecture, almost always start a statin, especially if the patient has more than 40. If no, look at the LDL cholesterol. Is it more than 130? Then yes, we treat with a statin. If it's no, if the LDL cholesterol is lower than 130, does the patient have any history of ASCVD? If yes, then you start a statin. If the patient has no ASCVD, is there presence of CKD? Then yes, but not dialysis. Okay. If not, then if the age is more than 45 and 2 or more risk factors, then you start statin. When we say risk factors, here, male, smoker, hypertension, BMI of more than 25, family history of premature coronary heart disease, proteinuria, LDH, and postmenopausal women. And then you reassess early on, after 6 to 8 weeks. No need to wait for like 3 or 6 months. Okay. And I think that's my last slide. So these are my references. So if you want further reading on this, you can download the guideline. It's freely accessible in the AFES website, or you just search it on Google. Okay. So this sounds like your good cholesterol is fine, but your bad cholesterol is plotting to hack into your computer, empty your bank account, and steal your life. So I think the message of this cartoon is sometimes it's really a silent disease. Most patients will not have any manifestations. You just need to make sure you include it in your annual screening. Okay, have a good afternoon. Bye-bye.